Welcome back to a video on left ventricular hypertrophy. Left ventricular hypertrophy could be of three types. One is concentric left ventricular hypertrophy, that is thickening of the walls of the left ventricle without enlargement of the cavity. That occurs in systemic hypertension when it is severe and long-standing, aortic stenosis, and coarctation of aorta. Eccentric hypertrophy, where the wall is thickened but cavity also gets dilated, can occur in chronic aortic regurgitation because of the volume overload. And a third variety is asymmetric septal hypertrophy. Septum is hypertrophied more than the posterior wall. That occurs in hypertrophic obstructive cardiomyopathy. In some variants of hypertrophic cardiomyopathy, there may not be asymmetric septal hypertrophy. Instead, there can be concentric left ventricular hypertrophy as well. This echo is from a concentric left ventricular hypertrophy. We will not be able to say the cause from this echo image alone. This is the place where you keep the transducer. Free wall of the right ventricle. This is the right ventricular outflow region. Interventricular septum. You may note that the borders are seen much better than the inner part of the septum. That's the usual. When there is a difference in the refractive index, that is between blood here and the septal wall, then the reflections of the echoes are much more. Same thing occurs here. There is an interface between blood which is sonolucent and interventricular septum. In between, there will be less echo density, and speckled pattern can be seen in hypertrophic cardiomyopathy. This is the left ventricular posterior wall. Again, you can see that inner portion is sonolucent because more of reflections occur at the edges. Echo is detection of the reflected ultrasound beam. This is left atrium, a bit dilated, aorta. So this is concentric left ventricular hypertrophy seen from the parasternal long axis view. This is the cross section of descending aorta. This is ascending aorta. This is descending aorta. You can see part of the coronary sinus also here in the atrioventricular groove. Some sonolucency is seen there. If coronary sinus is dilated, as in left superior vena cava draining into the coronary sinus, then this region can be bigger. Parasternal short axis view, perpendicular to the previous parasternal long axis view. This is the cavity of the left ventricle, and this is the thickened septum. Here also you can see that the edges are better seen than the inner portion of the myocardium. You can see the cross section of the papillary muscles on either side. So this is a cross section at the papillary muscle level. And while taking measurements of the left ventricular thickness to risk stratify hypertrophic cardiomyopathy, we have to take multiple sections. This is section at one level. We can take distal sections and proximal sections and other views also, and take the septal thickness where it is maximum. That is how it is useful in risk stratification of hypertrophic cardiomyopathy. When it is done for other causes of concentric left ventricular hypertrophy, that may not be so important. This is one of the older modes of echocardiography known as M mode or time motion mode or TM mode, currently used as M mode only. And earlier era, it was used for evaluation of valvular heart disease like mitral stenosis, where specific pattern was noted on mitral valve echocardiogram. Similarly, for evaluation of pulmonary hypertension, specific pattern of pulmonary valve M mode echocardiogram was there. but all those are seldom used these days. Still, for left ventricular measurements, mode echocardiography is still used in most of the laboratories, even though more accurate will be 2-dimensional or 3-dimensional measurements for assessment of left ventricular ejection fraction. This is just an ice-pick view. Along the cursor, this axis will be the distance from the transducer. This axis will be time. And a mode has high temporal resolution because this is usually taken at a higher sweep speed. This is the corresponding 2-dimensional image. You can see that it is at the interventricular septum beyond the mitral wall. This is the anterior mitral leaflet. This is the tip of the anterior mitral leaflet here. So this is beyond that, almost at the papillary muscle level or caudal level. Typically, it is taken at the caudal level for left ventricular measurements. We will see the measurements. This is interventricular septal diastolic, 2 centimeter. And this is that measurement, interventricular septum diastole. Diastole is identified when the septum and posterior wall are farthest apart. And this is systole when they come together in contraction. This is left ventricular internal dimension diastolic, that is this dimension. Then left ventricular posterior wall diastolic, this dimension, markers you can see here. Interventricular septum systolic, that is this measurement. Left ventricular internal diameter systolic, that is this measurement. Left ventricular posterior wall systolic, this measurement. To say asymmetric septal hypertrophy, we will compare these two diastolic measurements. Compare the septal and posterior wall. Usually they will be nearly equal. Here you can see 2.03 versus 1.71. Slight difference is there. Septum is a little bit more. But in asymmetric septal hypertrophy of hypertrophic obstructive cardiomyopathy, it will be much more. Then end diastolic volume. These are direct measurements which you take using the cursor. These are measured from these values by the computer and the echocardiograph. Left ventricular mass ratio, that is IVS to posterior wall, 1.19. That's not very much elevated. Fractional shortening of the left ventricle, and systolic volume, stroke volume, and ejection fraction. Transducer is kept near the apex. Ideally, it should be exactly at the apex. You can see the thickened interventricular septum and free wall. This is the interatrial septum, atrioventricular junction. You can see the closed tricuspid wall, closed mitral wall, right ventricle, right atrium, left ventricle, left atrium. And these translucencies are the pulmonary veins draining into the left atrium. We can see that the right atrial wall is rather smooth without any translucency, while there are translucencies here. Usually we see 3 pulmonary veins draining into the left atrium. In live image you can see it better, and you'll also be able to see the color flow in color Doppler. You can see the blood flowing, or rather the Doppler signals of blood flowing from the pulmonary veins into the left atrium.